All right, today we are jumping right into the middle of a high-stakes medical mystery. We're talking about a situation where everything seems fine until it's not. It's a race against the clock where a calm, systematic approach is literally the only thing that can save a life.
So, picture this. The surgery, the hard part, is over. The team did their job, the patient is closed up, and you can almost feel that collective sigh of relief in the room.
Now, the patient is in the recovery room. They're being monitored, everything looks good. It seems like they're on the straight and narrow path to getting better.
And then, out of nowhere, that quiet is just shattered by a piercing alarm from a monitor. You look at the screen and the numbers are dropping, and they're dropping fast. This isn't just a warning, this is a full-blown crisis.
The team has maybe minutes, if not seconds, to figure this out. What in the world is causing this sudden, catastrophic drop? The patient's life hangs on getting the right answer.
Okay, so let's break this down like a detective story. To solve this mystery, doctors immediately have a lineup of four main suspects, four different types of shock that could be the culprit here.
Suspect number 1, and by far the most common cause after an operation, is hemorrhagic shock. Put simply, the patient is bleeding somewhere. They're losing blood, and that means the volume in their system is dropping dangerously low.
Next up, suspect number 2, cardiogenic shock. Now this one's different. The problem isn't the amount of blood in the system. The problem is the pump. The heart itself is failing and just can't push the blood around the body like it's supposed to.
Our third suspect is obstructive shock, and the name kind of says it all. Think of this like a huge traffic jam or blockage on a major highway. The blood is there, it wants to go, but something is physically in the way, stopping the flow.
So what could cause a blockage like that? Well, two classic examples are a tension pneumothorax, where a collapsed lung actually starts to squeeze the heart, or a pulmonary embolism, which is a nasty clot that gets stuck and blocks a major artery in the lungs.
And that brings us to our fourth and final suspect, distributive shock. With this one, the pump is fine, the blood volume is fine, but the pipes, the blood vessels themselves, are the problem. They've all relaxed and opened up way too wide, causing the pressure to just bottom out. And what could trigger that? Well, you're looking at things like a massive allergic reaction, what we call anaphylaxis, or a huge body-wide infection that's spiraled out of control, which we know as sepsis. Both are incredibly dangerous.
Okay, so we've got our four suspects lined up. How on earth do you figure out which one it is when the clock is ticking like this? Well, you start by looking for immediate, physical clues.
First things first, you go right back to basics. Airway, breathing, circulation. You have to stabilize the patient while you're figuring this out, and as you're starting resuscitation, you're doing a super fast physical exam, looking for any telltale signs. The patient's own body gives you the first big clues. It's like it's trying to tell you what's wrong. For instance, is the patient's skin really pale? That screams blood loss. Are they struggling to breathe when they lie flat? That could point to a heart problem. And a swollen belly or surgical drains that are suddenly filling up? That's a huge red flag for internal bleeding. So, physical clues are a great start. But to really narrow down the suspects, doctors often rely on one key piece of data. It's called central venous pressure, or CVP. And this one number can be an absolute game changer. And what's so brilliant about this is how it splits our four suspects right down the middle into two distinct teams. If the CVP is low, that suggests a volume problem. Either the tank is empty from bleeding or the pipes are too wide. But if the CVP is high, that tells you there's a backup, a traffic jam, caused by either a failing pump or a physical blockage. And this is why all that detective work is so important. Once you've identified the right culprit, you can hit it with a very specific, targeted treatment. Because, giving the wrong treatment here could be just as deadly as doing nothing at all. So let's say all the signs point to our prime suspect, hemorrhagic shock. The patient is bleeding. What do?
The response has to be fast and has to be direct. First, you've got to pour back in what's being lost, fluids, blood, whatever it takes. But that's just buying time. The real fix? You've got to get that patient back to the operating room, find the leak, and plug it. Now.
But what if the CVP was high and all the clues were pointing to the heart? Well, now you're looking at a completely different playbook. And get this, the treatment is basically the opposite of what you do for bleeding. You're not going to pump them full of fluids. That would just overwhelm the struggling heart. Instead, you might restrict fluids and focus on special medications to help the pump do its job. It's the same idea for obstructive shock. You have to relieve the blockage immediately. And finally, let's look at one of the really tough ones to manage, sepsis, which is a type of distributive shock.
Treating sepsis is like fighting a war on multiple fronts all at once. Yeah, you give fluids to fill up those dilated blood vessels, but you're also immediately hitting them with powerful antibiotics. You're using other drugs to support the heart, and you might even have to go back to surgery to drain whatever's causing the infection. You're doing the whole shebang.
It really makes you appreciate the process, right? When every second counts, this is how medicine takes a moment of pure chaos and turns it into a clear, methodical, life-saving plan. It's an absolutely incredible example of thinking under pressure.